A neurologist can learn more about you in the 10 seconds it takes you to walk down a corridor than from most of the tests that follow. That is not an exaggeration. Experienced clinicians frequently form a working diagnosis before the patient has reached the chair because walking is not one skill. It is dozens of systems performing together in a sequence you learned before you could speak and have not consciously thought about since. When one of those systems falters, it shows up in the pattern. And the pattern is visible to anyone who knows what to look for. Today, I am going to teach you what to look for, not just how fast you walk. That has been covered, and I will touch on it briefly because it is genuinely important. But the more useful information is in how you walk, the shape of it. I'm going to describe 6 different walking patterns and tell you what each one points toward. And there is one in particular that I need you to hear. It is a condition that causes a very specific walk, along with memory changes and bladder problems. It affects somewhere around 4% of people over 65 and closer to 9% over 80. It is routinely mistaken for Alzheimer's disease, Parkinson's disease, or simply for old age. And unlike those, it can often be treated with substantial improvement in a majority of correctly selected patients. Yet studies suggest only a small fraction of affected people in the United States ever receive treatment for it. If you have a family member whose walking, memory, and bladder have all changed together, please stay to that part. It may be the most important thing you hear this month. Let me start with speed, briefly. The headline research is that walking speed predicts survival about as well as a full medical history does. But there is a second finding that I think is more useful and fewer people know it. In 2013, Dr. Joe Verghese at the Albert Einstein College of Medicine proposed something called motoric cognitive risk syndrome. The definition is remarkably simple. 2 things together, slow walking speed, plus the person's own complaint that their memory is not what it was. That is it. No brain scan, no neuropsychological testing. Studies across multiple countries have found this combination identifies people at meaningfully elevated risk of developing dementia. And a meta-analysis found it predicted cognitive impairment better than either slow gait alone or memory complaint alone. The combination carried more information than either piece. Now, why on earth would walking speed predict a memory disease? Because walking is a brain activity. Coordinating gait requires the same frontal circuits involved in planning, attention, and executive function. Research suggests gait speed can begin declining years before mild cognitive impairment is diagnosed. In some analyses, more than a decade before. So the legs are frequently reporting the problem before the memory does. I'm not telling you this to frighten anyone. I'm telling you because both halves are actionable. If your walking has slowed and you have noticed memory changes, that combination is worth an evaluation, and a great many causes of both are treatable. Now let me get to the patterns because this is where it becomes genuinely practical. Pattern number 1, and this is the one I want you to look for in the people you love. Watch someone's arms while they walk. Normal walking includes an automatic arm swing opposite to the legs. Right leg forward, left arm forward. You never think about it. Now, here is the sign. If one arm swings noticeably less than the other, that asymmetry is meaningful. Reduced arm swing on one side is frequently one of the earliest visible signs of Parkinson's disease, and it often appears before any tremor. Families sometimes notice it in old photographs or videos years before diagnosis. Other early features of the same picture include a shorter stride, feet that scuff or shuffle, difficulty turning so that the person turns in several small steps rather than pivoting, and reduced facial expression. Now, please hear the caution. An old shoulder injury, a frozen shoulder, or simply carrying a bag will reduce arm swing too. One asymmetric arm is not a diagnosis. But if it is persistent, and especially if it comes with any of those other features, that deserves a neurological assessment rather than being watched for another 2 years. I mention this because early Parkinson's is very commonly attributed to aging, and treatment makes a substantial difference to quality of life. Pattern number 2 is a wide base. Watch whether someone walks with their feet noticeably further apart than shoulder width, as though they are on the deck of a boat. Widening the base is what the body does when it does not trust its balance information. The common causes include cerebellar problems and peripheral neuropathy, where the nerves in the feet are no longer reporting position accurately. Here is a distinguishing clue that is genuinely useful. If the unsteadiness is dramatically worse in the dark or with the eyes closed, that points toward the feet rather than the cerebellum, because vision was compensating for the missing information from below. The common causes of that neuropathy include diabetes, vitamin B12 deficiency, thyroid disease, alcohol, and certain medications. B12 deficiency in particular is common in older adults, especially those on metformin or long-term acid-reducing medication, and it is a simple blood test and a simple correction. If this is useful to you, tell me in the comments whether your balance is worse in the dark. I read everyone. Pattern number 3 is the limp, and there are two kinds worth distinguishing. The first is straightforward. If someone spends less time standing on one leg than the other, that is usually pain, and the usual culprits are hip or knee arthritis. The second is more interesting and gets missed. Watch the hips from behind. If the pelvis drops down on the side of the leg that is off the ground, or the person leans over the standing leg to compensate, that indicates weakness in the hip abductor muscles rather than pain. That is a mechanical problem with a mechanical solution, and targeted strengthening genuinely helps. It matters because hip abductor weakness is a significant and correctable contributor to falls, and it is rarely identified unless someone is watching for it. Pattern number 4 is the foot that slaps. If you can hear one foot landing more loudly than the other, or the person lifts that knee unusually high to clear the ground, that is called foot drop. It means the muscles that lift the front of the foot are weak, and the person is compensating by hoisting the whole leg. The causes include nerve compression in the lower back, a compressed nerve at the outside of the knee, and various neuropathies. Some are correctable, and there are also simple braces that substantially reduce trip risk while the cause is being sorted out. This one matters because a toe that does not clear the ground is a very direct route to a face-first fall. Pattern number 5 is about when the walking fails rather than how. Two conditions cause leg pain that comes on with walking, and telling them apart is genuinely useful. The first is peripheral artery disease, where narrowed arteries cannot supply enough blood to the working muscle. The pain is usually in the calf. It comes on after a fairly predictable distance, and it eases within a few minutes of simply standing still. The second is spinal stenosis, where the canal carrying the nerves in the lower back has narrowed. Here is the distinguishing feature, and clinicians actually call it the shopping cart sign. People with spinal stenosis feel considerably better when leaning forward because bending forward opens the canal slightly. They can push a shopping cart around a supermarket for an hour with no trouble, then struggle to walk the same distance upright in a car park. Walking uphill is often easier than downhill because uphill involves a forward lean, and standing still does not relieve it the way it relieves the artery problem. Sitting down does. Both conditions have real treatments, and knowing which one you have determines which specialist you need. And now, pattern number 6, which is the one I asked you to stay for. Watch for feet that seem stuck to the floor. Clinicians call it a magnetic gait. The person takes short, shuffling steps with the feet barely leaving the ground, and they often have particular difficulty starting to walk and turning around. Their feet appear glued down. Now that alone can mean several things, but the pattern I want you to know is a triad. 3 things together. That walking change, plus urinary urgency or incontinence, which is often the second thing to appear, plus cognitive slowing, meaning the person is slower in thinking and processing rather than losing memories in the way Alzheimer's typically presents. That combination has a name. It is normal pressure hydrocephalus. Here is what is happening. Your brain sits in cerebrospinal fluid, which is continuously produced, circulated, and absorbed. In this condition, the balance between production and absorption goes wrong, and fluid accumulates in the ventricles, the internal chambers of the brain. The pressure measures normal, which is why the name is confusing, but the enlarged chambers press on the nerve fibers running just beside them. And it happens that the fibers controlling the legs and the bladder run closest to those chambers, which explains the specific triad. Now, the numbers. A population-based study found a prevalence of about 3.7% among people 65 and older, rising to nearly 9% in those 80 and above. And here is the part that matters most. It is one of the very few reversible causes of dementia-like symptoms. Treatment involves surgically placing a shunt to drain the excess fluid, and reported improvement rates in appropriately selected patients are commonly in the range of 60 to 80%. Gait tends to respond best and fastest, and yet one analysis noted that only a small percentage of affected patients in the United States receive specific treatment for it. It gets diagnosed as Alzheimer's, as Parkinson's, or as ordinary aging. Now, 3 honest caveats, because I will not oversell this. Not everyone with these symptoms has it, and the majority will turn out to have something else, most commonly vascular dementia. Diagnosis requires brain imaging and usually a test where fluid is drained to see if walking improves. Shunt surgery carries real risks and is not right for everyone. But the outcome of treatment worsens as the condition progresses, which is exactly why early recognition matters so much. So if the 3 things arrive together in someone you love, walking, bladder, and thinking, please ask specifically about normal pressure hydrocephalus. Ask by name. That request costs nothing, and it is the reason I made this video. Now, let me be clear about what is normal, because I do not want to leave anyone anxious. Gradually walking a little slower over many years is ordinary. Taking slightly shorter steps is ordinary. Being more careful on ice, on stairs, or on uneven ground is sensible, not pathological. What is not ordinary is a change over weeks or months rather than years. A change on one side only. A change that arrives alongside something else, such as memory, bladder, speech, or vision. Or a new fear of walking that has appeared without an obvious reason. 3 honest statements before I close. I have described patterns, not diagnoses, and many conditions produce overlapping walks. You cannot diagnose yourself or a family member from a video, and I would not want you to try. And this is education, not medical advice. I am a physician, but I am not your physician. Now, the things that need urgent attention: sudden weakness, numbness, facial droop, or slurred speech is a stroke until proven otherwise, and that means emergency services immediately. New difficulty walking developing over hours or days is urgent. Leg weakness with any bladder or bowel change or numbness in the saddle area can indicate spinal cord compression and needs emergency assessment, not an appointment next month. And any fall in the past year deserves mentioning to your doctor, even if you got up and told nobody. Let me finish with this. I called this video How Fast You Walk, and speed genuinely does predict a great deal. But I would rather you took away something more useful than a number. Watch the arms of the people you love. Notice if one swings less than the other. Notice if someone's feet look stuck to the floor. Notice if the walking, the bladder, and the thinking all changed in the same year. Notice if a limp is pain or is the hip dropping. Doctors get a 10-second corridor. You see these people every day. You are in a far better position to notice a change than any of us are, and the change is usually visible long before anyone books an appointment. Tell me in the comments if any of these patterns sounded familiar, either in yourself or in someone you care about. And if it was the last one, the feet stuck to the floor with the bladder and the memory, please do not wait on it. Take care of yourselves, and I will see you in the next one.